Welcome to our webinar titled MDS and PNH Overlap. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions or comments at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Shamalia Navada, who is an associate professor at Mount Sinai and a faculty member of the Tisch Cancer Center. Her focus is on clinical and translational research in myelodysplastic syndromes and acute myeloid leukemia. She has worked on designing early phase clinical trials, investigating the role of novel candidate drugs to improve the outcomes for patients with MDS and AML, and has served as the principal investigator on multiple investigator-initiated and industry-sponsored trials. She also has a Master's of Science degree in clinical research. Welcome, Dr. Navada. It's so great to have you. Thank you for joining us today.
Thank you so much for having me. Can you see my screen okay?
Yes.
Great. So the title of my talk today is Understanding the Overlap Between MDS and PNH. And the objectives of this talk are to provide an overview of both MDS and PNH, as well as discuss the potential overlap between MDS and PNH, including the diagnostic process as well as treatment strategies. So I'm going to first start by talking about the myelodysplastic syndromes. MDS is a clonal hematopoietic stem cell disorder, and the clinical features include poor cell growth and differentiation. There's often a hypercellular marrow, so a lot of cells being produced, but they're not maturing properly, and this leads to low peripheral blood counts. Patients, the median age of patients with MDS is 65 to 75 years, and the complications typically arise due to bleeding and infection. Bleeding from thrombocytopenia or low platelet count, and infection from neutropenia or low white blood cell count, the neutrophils being a component of that. In addition, about 35 to 40% of patients who have MDS may transform to acute myeloid leukemia during their disease course. For many patients who have MDS, the etiology is unknown. However, we do know that patients are more prone to getting MDS as they get older. Certain prior chemotherapy or radiation for other cancers can lead to MDS. There's some association with environmental exposure, such as benzene or petrochemicals. There is an increased risk of MDS in people who smoke, and there are some hereditary cases of MDS. As I mentioned, MDS, the clinical diagnosis is usually first manifested by cytopenias or low blood counts. In order to truly make a diagnosis of MDS, a patient then has to undergo a bone marrow aspirate and biopsy, at which time we can stage a patient using a scoring system called IPSS or IPSS-R, and we look at several components of the patient's bone marrow and blood information, such as their blood counts, the percentage of blasts or immature cells, the chromosomal abnormalities, as well as now mutational status to help prognosticate a patient with MDS. MDS, although it is a distinct entity, can have clinical overlap with many other bone marrow failure disorders. And here you see a schema of that. So you can have an MDS patient who has a PNH clone. You can have an MDS patient who has a hypocellular marrow and features of aplastic anemia. And you can have MDS overlap syndromes with myeloproliferative neoplasms. So you see here that there are many overlapping disorders, and today our focus is going to be predominantly on patients who have MDS and PNH. So I'd like to give you a bit of an overview on PNH, or paroxysmal nocturnal hemoglobinuria now. So it is a rare acquired hematopoietic stem cell disorder. And PNH is characterized by hemolysis, or a breakdown of red blood cells, which in turn leads to anemia, thrombosis, or blood clots, and low blood counts. The reported incidence of clinically significant disease is in the range of 1 to 10 cases per million. So as you can see, it's a rare entity. And it may be underestimated due to underdiagnosis. PNH is mostly a disease of adults, but the median age here of onset is in the 30s, as opposed to MDS, where you saw that the median age was more so in the 60s to 70s. It affects males and females similarly, even though it is caused by a mutation of a gene on the X chromosome. And there's no known ethnic or geographic distribution, although there is an increased risk of thrombosis in patients from the US and Europe compared to Asia. So why do people get PNH, or how do people get PNH? It is caused by a somatic mutation of the PIG-A gene, and this results in either partial or complete absence of the synthesis of the membrane GPI anchors, and that is the driving factor for hemolysis. And I'm just going to show you a few depictions of how that happens. So in this schema here, you can see a normal hematopoietic cell. And here you see these GPI anchored proteins anchored to CD55 and CD59. But here's a PNH cell where you are missing those proteins. And when you're missing those proteins, that causes dysregulation of the complement system. So normally, those proteins help to regulate the complement system. And when it's dysregulated, you have formation of this membrane attack complex, which causes inflammation and cell lysis, and increases the risk of thrombosis. And this is where the lack of those proteins causes this dysregulation of the complement system. What are the symptoms of PNH? So there are many different symptoms a patient with PNH can have. And here you see symptoms that, in general, probably 40+% of patients experience, including dysphagia or difficulty swallowing, pulmonary hypertension, which can cause shortness of breath, swelling, abdominal pain, kidney disease, you can have blood clots, and fatigue, among others. So there are many different symptoms a patient with PNH can have. Again, not all patients are going to have all of these symptoms, and some patients may actually remain asymptomatic. The diagnosis of PNH is typically delayed anywhere from 1 to 10 years due to this wide range of symptoms and also the rare nature of disease, so some clinicians may not think about looking for it right away. In addition, the name paroxysmal nocturnal hemoglobinuria, if you think of the literal name, means having dark urine often at night and on occasion, but nearly 3/4 of patients do not present with this hemoglobinuria or dark foamy urine, and so a clinician may not think about it, nor may a patient. One of the biggest complications in PNH is thrombosis or blood clots, which can occur in up to 40% of patients and can contribute to end organ damage, including lung damage, liver, and kidney. It can be the presenting symptom, and it may be correlated with the size of the PNH clone. So thrombosis is more common in patients who have a PNH clone of greater than 50%, as opposed to a patient who has a very small PNH clone. And the thrombosis can also occur in unusual locations, which I'll show you shortly. We also know that patients with PNH are 62 times more likely to have a venous thromboembolism compared to the general population, and that the relative risk of clotting is greater in PNH versus other inherited clotting disorders that we often look for in patients. Although thrombosis typically involves the venous system, both venous and arterial clots can occur. And as I mentioned, they can occur in atypical locations like in the abdomen, like portal vein thrombosis, intracerebral, so in the brain, skin, and lower extremities. So when a patient has an unusual clot, they should be tested for PNH unless another etiology is definitively known. In terms of managing the thrombosis, acute thromboses are managed with blood thinners or anticoagulation, but we don't typically recommend primary prophylaxis with an anticoagulant to prevent clots in patients who've not had a prior clot. So what are the labs we typically send in PNH? So some of the labs that we would send include the lactate dehydrogenase level, better known as the LDH. And this is an enzyme found in red blood cells that's released during hemolysis and therefore is often elevated in patients with PNH. Patients with PNH may have an elevated creatinine, which is their kidney, represents their kidney function, although that's not always the case. They may have a low platelet count. A platelet count is what measures how well the blood is clotting. But the diagnostic test we use in patients with PNH is high sensitivity flow cytometry. And this test can be run on peripheral blood, so just a tube of blood that's drawn, as opposed to MDS, where we need to do a bone marrow, aspirate, and biopsy for the diagnosis. PNH can be diagnosed from peripheral blood. And this flow cytometry test measures the number of red and white blood cells affected by PNH in a sample of circulating blood, and it can also measure the clone size. So what it does is it uses monoclonal antibodies against these GPI anchored proteins that I showed you earlier, including CD55 and CD59. So the PNH clone are the cells missing these GPI anchored proteins. So who should be tested for PNH? So any patient who has intravascular hemolysis as evidenced by hemoglobinuria, and it's unexplained. And they may also have iron deficiency, they may have abdominal pain, they may have other low blood counts. Any patient who has a blood clot or thrombosis with unusual features, as I mentioned, those unusual sites. And then patients who have bone marrow failure. So patients who have aplastic anemia, patients who have MDS, or refractory and cytopenias of unknown etiology. Those patients should be tested for PNH. And here, this chart shows you the incidence of PNH clones in various other disorders. So, I mentioned in aplastic anemia, you can also have a PNH clone, and here about a quarter of patients with aplastic anemia have a PNH clone, as opposed to, as you see here, a much lower percentage of patients with MDS. So about 5 to 6% of patients with MDS will also have a PNH clone. And this often occurs, if it does occur, with patients who have lower risk MDS, or as you see, the AAMDS, which is refractory anemia. So PNH clones have been identified, as I mentioned, in more than 1 out of 4 patients with aplastic anemia and more than 1 out of 18 patients with MDS. And patients with MDS are more likely to present with the PNH clone if they also have a hypocellular bone marrow. So, they don't have as many cells being produced in the marrow. Many of them have normal cytogenetics, HLA-DR15 positivity, and moderate to severe thrombocytopenia. So to shift gears to discuss PNH and bone marrow failure a little more, so I mentioned PNH clonal expansion is frequent in aplastic anemia. It's associated with HLA-DR2, and the presence of a PNH clone predicts response to immunosuppression in patients with aplastic anemia and MDS. So patients who have a PNH clone may be more likely to respond to immunosuppression such as ATG and cyclosporin. All patients with aplastic anemia should be screened for PNH, since about 25% of patients will have a clone. Now, if it's persistently negative, those patients should be tested every 6 months for 2 years, and then move to annual testing unless signs or symptoms develop. Now, if the PNH screen is or becomes positive, then the patient should be tested every 3 months for the first 2 years, and then only reduce the frequency if the proportion of the PNH cells has remained stable. But if it appears that the clone is increasing, then the patient should be monitored regularly. What about MDS? So the co-occurrence of clinically significant PNH and MDS is rare. Typically, the diagnosis of PNH precedes that of MDS or occurs at the same time. So you may have a new patient with MDS and you happen to test for the PNH clone and you see that clone and then you see that they're concurrent. It's less likely that a patient would have MDS for a long time and then develop PNH. So MDS patients should be tested for PNH at diagnosis, but they don't need routine testing afterwards unless there's some unexplained hemolysis or unusual thrombosis that prompts you to do that evaluation. On the other hand, a patient with PNH should be monitored for MDS, typically by blood counts. And if you start to have unexplained cytopenias, for example, the blood counts are low and there's no clear etiology, then a patient should undergo a bone marrow to assess for MDS, because PNH patients can develop MDS over time. So now I'd like to talk a little bit about treatment for these patients. So it's important to note that PNH can be divided into these different categories here. So subclinical PNH. For subclinical PNH, which I'll go into a little more detail shortly, no specific PNH therapy is usually needed. So you want to focus on the underlying bone marrow failure disorder. Now, when you have a PNH bone marrow failure disorder overlap, you typically want to focus on the bone marrow failure disorder. So for example, with PNH and MDS overlap, in most cases, you want to focus on the MDS. However, if a patient has a large PNH clone, or if they have symptoms related to PNH, they may also benefit from PNH-related or directed therapy, such as Eculizumab. And then classic PNH, without the bone marrow failure syndrome, these patients you would automatically treat with Eculizumab. And so, again, our focus today is on the PNH MDS overlap, but I'll talk a little bit about treatment for MDS as well as treatment if you had a large PNH clone, so that we can cover all these bases. So I mentioned here I would talk a little bit about this classification of PNH. So in subclinical PNH, as you see on the bottom here, there's really no clinical evidence of intravascular hemolysis, but in the bone marrow, you will see evidence of a concomitant bone marrow failure syndrome. When you find a PNH clone in these patients, it's usually small. It's less than 10% of the population of GPI anchored proteins. And these patients typically would not benefit from Eculizumab. Now, PNH in the setting of another bone marrow failure syndrome, for example, aplastic anemia or MDS, you sometimes will have mild evidence of hemolysis. For example, you may have an elevated LDH, you may have an elevated reticulocyte count or hyperbilirubinemia. The bone marrow, again, will show an evidence of a concomitant bone marrow failure syndrome. And although variable by flow cytometry, the percentage of the GPI anchored proteins or the PNH clone is usually relatively small. So it's often less than 50%. Now, for these patients, you typically are not going to give them Eculizumab, but some patients may have a large clone and clinically significant hemolysis, and they may benefit from PNH-directed treatment. And then in classic PNH, you will see florid hemolysis on the bone marrow. You may see some erythroid hyperplasia. Those are the red blood cell precursors. You often won't see other features of bone marrow failure. You often have a large PNH clone of greater than 50%, and these patients definitely benefit from Eculizumab. So I mentioned for these PNH patients with concurrent bone marrow failure, for example, MDS, you would want to focus on the treatment of the bone marrow failure syndrome first. So I want to talk a little bit about how you would treat the MDS. So first of all, with MDS, we risk stratify into lower risk, which you see here, where the goal is to improve marrow function and reduce the number of transfusions a patient needs. And then also higher risk, where the goal is to stabilize the marrow and move to more definitive therapy and to often consider bone marrow transplant. So for lower risk, sometimes these patients can just be monitored. You may be able to treat them with growth factors. Some of the treatments we have include lenalidomide, particularly for patients with the deletion 5q, and then hypomethylating agents such as azacitidine and decitabine, which are the standard treatments that we use for higher risk MDS. And then you want to consider a bone marrow transplant if a patient has higher risk MDS and is an appropriate candidate with an appropriate donor. So patients who have, concurrent MDS with PNH should be evaluated for bone marrow transplant when available, particularly if they have higher risk disease. I mentioned a lot of these patients will tend to be younger who have the PNH clone, and many of them, if they have a donor, should be at least evaluated for transplant. But prior to transplant, they may need treatment with hypomethylating agents, particularly if they have a high percentage of blasts, and the goal is to reduce the burden of disease before going to transplant. Now, for those lower risk patients, the refractory anemia with MDS, they may be able to get growth factors, have their PNH clone monitored by blood draws, and they may not need any treatment right away, or may not need a transplant right away, and may just be able to be monitored for many years before considering further therapy. Now, what if a patient has a clinically significant PNH clone, or they have symptoms from PNH like hemolysis or thrombosis? Then, in addition to transfusions, if there's hemolysis, or anticoagulation if there's thrombosis, you also want to consider PNH-directed therapy, and this includes Eculizumab or Ravulizumab. Eculizumab is a humanized first-in-class anti-C5 antibody, and you can see the structure of that here. And it's anti-complement therapy, and it's recommended for patients who have PNH who develop extreme fatigue, thrombosis, transfusion dependence, so they're requiring frequent red blood cell transfusions, frequent symptoms of smooth muscle dystonia, significant renal insufficiency, so they have kidney damage, or if they have any other end organ manifestations, they should be treated for their PNH. Eculizumab can be administered in the outpatient setting. The standard dosing is 600 milligrams IV once per week for the first 4 weeks, and then 900 milligrams every 2 weeks afterwards, and this is continued indefinitely. And in patients treated with Eculizumab, it significantly reduced the morbidity and mortality in patients with PNH, as seen by an 87% reduction in hemolysis measured by LDH, 92% reduction in thrombotic events, 73% reduction in transfusion dependence, a 78% reduction in fatigue, and the drug was generally well tolerated, with the adverse events in the trials similar to placebo. So you can see here that in patients who got Eculizumab during treatment, 49% of the patients had stabilized hemoglobin level in the Eculizumab group compared to no patients in the placebo group. And these patients also had an improvement in their quality of life and symptoms as measured by various scales. Here you see the change from baseline in fatigue, and the patients who received Eculizumab had a significant improvement in fatigue as compared to the patients who got placebo. So although Eculizumab is quite effective, it does not treat the bone marrow failure associated with PNH. It can treat that abnormal PNH clone, but it doesn't actually treat the MDS, which would need to be treated with MDS-directed therapy if needed. It also does not normalize the hemoglobin because it doesn't compensate for the CD55 deficiency. And so there are novel agents in trials right now that are attempting to further improve the hemoglobin to try to help prevent the fatigue that patients may still have if they're on these agents. Although well tolerated, some of the side effects of eculizumab include headache, which is more common with the first dose, and increased risk of meningococcal infections. And so patients should receive the meningococcal vaccination at least 2 weeks prior to receiving the first dose of treatment, and they should be monitored for any signs or symptoms of meningococcal infection. This is very important. In terms of monitoring patients who are on eculizumab, they should receive monthly tests of a blood count, a reticulocyte count, a bilirubin, and an LDH. And this is to assess for hemolysis, as well as a yearly flow cytometry at least to assess for the PNH clone. And by getting these blood tests, you can also assess whether there's some unexplained cytopenias, and if there are some, then that would prompt a bone marrow biopsy, as I mentioned earlier, if there's no other reason to look for a bone marrow failure disorder. I also would like to mention ravulizumab, which is a new complement C5 inhibitor. And this is a long-acting agent. So instead of requiring treatment every 2 weeks, it requires treatment every 8 weeks. So patients who are not able to get to the office every 2 weeks, particularly with the COVID pandemic recently, it is much easier for patients to get to the office every 8 weeks rather than every 2 weeks. And in studies, the safety and tolerability of ravulizumab were similar to eculizumab. And this agent is indicated for complement inhibitor naive patients, so patients who've never been treated for PNH, as well as patients who were previously treated with eculizumab and then want to switch to a longer acting agent. So you see here the structure of ravulizumab, and similar to eculizumab, it acts, it's an anti-C5 agent and monoclonal antibody. And I just want to show you the efficacy results. So here we see that patients who received ravulizumab up front, they actually had some improvement even compared to eculizumab in terms of reduction in transfusions and LDH normalization. And patients who were previously on eculizumab also had success on ravulizumab in terms of hemolysis, fatigue scores, and reduction in transfusion requirements. So overall, the study showed that ravulizumab is non-inferior to eculizumab for treating PNH patients, either naive to complement inhibitor therapy and those who previously received eculizumab. And it has a favorable dosing schedule with that every 8-week schedule and fewer episodes of breakthrough hemolysis. So many patients have been using this therapy who have a significant PNH clone. So I want to conclude by saying that the overlap between MDS and PNH exists, but it is rare. When patients have both MDS and PNH, it is characterized by low blood counts, but it can also present with hemolysis or thrombosis. Bone marrow failure syndrome is often the focus of treatment, and you want to consider a bone marrow transplant referral depending on the patient's individual characteristics. But if a patient has a significant PNH clone, eculizumab and ravulizumab significantly reduce the morbidity and mortality in patients with PNH. Thank you for your attention.
Thank you so much for the wonderful presentation. We have a few questions. Does the dual diagnosis of MDS and PNH complicate treatment outcomes for patients who have a dual diagnosis?
So it depends on the way that the diagnosis, or depends on kind of the features of both diagnoses. So a patient could have a dual diagnosis and never need treatment for the PNH if they have a small PNH clone. Many times the dual diagnosis will focus on treatment of the bone marrow failure disorder, and the PNH clone can just be monitored. However, there are cases where a patient with this PNH clone, the PNH clone may have an increase in clone size may develop more hemolysis and may actually need treatment for the PNH, in which case it could complicate it because a patient may need additional treatment. So I would say in the majority of cases, even though it's rare, that it may not be a complication, but there are cases in which it would be.
If a patient were to have a bone marrow or a stem cell transplant for MDS, and they also have PNH, a small clone size, will the bone marrow transplant not only potentially cure the MDS, but does it also is there a potential cure for the PNH as well?
Yes, so there would be a potential cure for both disorders. And so, it's one of the reasons you'd want to consider a bone marrow transplant referral, particularly with a patient who has, significant disease burden. In fact, bone marrow transplant has been used for patients with PNH who are refractory to other therapies. But now that we have really good treatments with Eculizumab and Ravulizumab, those are often used in lieu of bone marrow transplant for PNH patients.
For a PNH patient who's already using treatment such as Soliris or Ultramarys, and then they become diagnosed with MDS, how does that change potentially their course of treatment? Being that the two diseases are treated with different therapies.
That's a good question. So at that point, I would recommend repeating doing a bone marrow aspirate and biopsy to characterize the MDS, see what the percentage blasts is, see if there's any chromosomal abnormalities. Is it lower or higher risk MDS? If we find a higher risk MDS, for example, then we may want to switch the therapy to focus more on hypomethylating agents for the MDS. Now, if a patient still has significant hemolysis or may need to continue would likely need to continue at that point the PNH-directed therapy as well, depending on the level of hemolysis. And then those are the patients who likely be wanting to evaluate for a bone marrow transplant. So it would change the treatment strategy where you may need to treat the MDS. Now, if you had a patient who had slightly lower blood counts and developed a lower grade MDS, you may not need to treat right away, but you would still need to monitor it more carefully because patients who have lower risk MDS can move towards higher risk MDS over time. So regardless, it would potentially impact the treatment strategy.
Thank you. And for MDS patients, I know we had talked about looking for testing for PNH. Is there a protocol for how often patients should be tested for certain other potential diagnosis? How do patients know how often they should be being tested for other bone marrow failure diseases?
So for MDS patients, I would recommend testing a diagnosis, but I don't typically continue to monitor my patients for PNH if they don't have a clone. If they have a clone, I will monitor it. If they don't have a clone, then I won't continue to test for PNH unless they develop some unexplained thrombosis or hemolysis that makes me want to recheck, because it's less likely that a patient with MDS who doesn't have a PNH clone at the beginning will develop one later on. If it's a PNH patient, I do monitor their blood counts and may be more likely to look for MDS because it would be more common for a PNH patient to develop MDS later on. But I do test MDS patients at diagnosis. Now, if they have a PNH clone, I would monitor it. I would say at least every 6 months, maybe more often, or sometimes even yearly, but maybe more often if the patient developed something unusual that may be prompt to test more often.
And with the news that we now have an FDA approval for a COVID vaccine, is there a consensus yet from the medical community about bone marrow failure patients being able to receive the COVID vaccine?
So I think that in general, we will be recommending the COVID vaccine for our patients. and immunosuppressed patients will likely be high on the list of patients who will get it. I don't think a consensus guideline has come out yet, but once the vaccine is available in general, I would recommend that patients speak to their provider about getting the vaccine. And I think in general, it would be recommended unless a patient has a contraindication for some other reason, for example, an allergy to a vaccine, like a severe anaphylactic allergy or something like that. Otherwise, I would recommend that that bone marrow failure patients get the COVID vaccine.
Thank you. And can you explain, what does transfusion dependence mean, and how does being transfusion dependent impact the effectiveness of treatments?
So transfusion dependence could mean a patient requires either red blood cell or platelet transfusions. And, transfusion dependence could mean any number of units, although often we think of a patient who's requiring, let's say, 2 units every 4 to 8 weeks as being transfusion dependent because they're requiring blood transfusions regularly. And, can definitely impact quality of life. One, because when a patient is anemic, they may be more fatigued, so they may not be able to do as much as they normally would be able to. And also because of time spent getting a transfusion. When we transfuse blood here, it often takes 2 to 3 hours to transfuse a unit of blood, which means a patient has to wait in the infusion center for that period of time. So, transfusion dependence can definitely impact quality of life. And when we see a patient who has transfusion dependence, whether they have PNH, MDS, or both, that often prompts us to treat the patient. So for PNH, it would be with things like Eculizumab, Ravulizumab. For MDS, it would be often, if it's just transfusion dependence, like red blood cells with lower risk disease, we may consider something like an erythropoiesis stimulating agent like Aranesp or Procrit. But one of our big goals in bone marrow failure syndrome states is to reduce the number of transfusions a patient needs or make them transfusion independent.
Thank you. High-risk MDS patients have a more likelihood of transforming to AML. Do we know whether low-risk or high-risk MDS patients have a likelihood of developing PNH?
So it's a little unclear because it's a rare entity. From the from the cases that presented in the literature, it appears that there may be a slightly higher incidence with the patients who have the AAMDS. I mentioned refractory anemia MDS, which are lower risk patients. However, there are also cases in the literature where patients had a high percentage of blasts and chromosomal abnormalities and had a PNH clone. And those are the patients you want to consider for transplant early on. So because it's rare, I don't think it's like well studied, but I think that the AAMDS are the ones where they've seen it the most.
Thank you. And is there any specific diet or anything for patients with bone marrow failure that's recommended for patients?
We don't have any specific diet we recommend. I would say, I always tell my patients that, it's always good to talk to a nutritionist. Many of our center, for example, but many centers will have a nutritionist that can help guide a patient in terms of foods that they should or shouldn't be eating. But I think there's no specific foods that, unless a patient has some type of deficiency, for example, if they're iron deficient or vitamin B12 deficient, then they will want to eat foods high in those vitamins or take vitamin supplements. But otherwise, there's no specific diet that's recommended.
Thank you. And for patients who are in the process of being diagnosed, are there any key questions that they should be asking of their doctor while they're either newly diagnosed or in the process of being diagnosed? It can be very overwhelming to be going through the process. So kind of knowing a few key questions to make sure that you're asking can be very helpful for patients. Do you have a few suggestions on what type of questions patients should make sure that they ask their physicians?
Yes, that's a very good question. I think that, for patients with any bone marrow failure disorder, whether it's MDS, PNH, or a combination of both, I think that, patients should try to understand where they are in the spectrum of the disorder. For example, with MDS, lower risk, higher risk. Trying to understand the different treatment strategies that are possible, and what side effects they may have from it. I think it's also important for patients to understand the impact of potential treatments on their quality of life, because I've had patients who come in for treatment, and over time it ends up being a burden to them or their caregivers to come in for treatment as often as they need to. So I think I'm trying to figure out the trajectory, not only for the immediate future, but for a year or two or so from the time of diagnosis. I think that also understanding the potential risks of treatments, whether it's risks of infection, risks of bleeding, other things like that, and how they could potentially prevent those risks. And then I think, especially now with COVID, just understanding what options they have that may require fewer treatments to the office, or maybe oral agents that they can use should be explored as well, or less frequent treatments. So I think there's a lot of things, and I think it's overwhelming. I think that I know the Aplastic Anemia MDS website has a lot of good suggestions too on initial questions and resources for patients. So I think that's another place to look to really kind of advise a patient and guide a patient through their disease.
Thank you so much, Dr. Navada, for spending your time and sharing your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family, as we have done for the past 37 years. This concludes our program today. Thank you. Happy holidays.